Rice.
All right, my name is Olivia Rice, and today I'm going to be talking about the trip that Dr. Shu and I just recently got back on, which is Honduras, through an organization called Restore 2023. And so I'm just going to highlight some of the major events during the trip and also kind of the background of Restore and how it came to be. So Dr. Shu first went down to Honduras in 2011 as part of a medical team for medical readiness training exercises as part of the Army. And he led this mission as an orthopedic trauma surgeon and also as a limb deformity expert. And many of you know this, but Dr. Shu actually went to both Russia and Italy as a resident, in fact, to learn from some of the masters of Elizarov technique for bone regeneration and subsequently deformity correction. And so Dr. Mirna Ochoa, which is blurrily photoed here, was a chief resident at the time during this first trip, and also just demonstrated a high level of understanding for limb deformity and an interest in the topic as well. And so this is Dr. Aviles, who was a family medicine doctor, but also the military attaché for the trip, and really suggested that Dr. Shu come back routinely due to the pretty significant demand for the skill set that he was teaching, which was primarily geared towards limb deformity and in the setting of infection. And so Dr. Shu agreed to this basically with one condition, which was that Dr. Ochoa would be the one to run the program, which was pretty significant considering she was about to be kind of sent off to the rural areas of Honduras, which happens pretty frequently after they complete residency training. And so the hospital administration agreed, and Dr. Shu has been going down there annually with Restore annually up until a brief hiatus during COVID. And so with Hospital Escuela, presidential board engaged, they established a team, and the concept of Restore was born, but the actual organization didn't become founded until a couple years later when Dr. Shu moved to Charlotte. And always creative with his acronyms, him and his colleagues appropriately named the organization Restore, which stands for Reconstructive Surgery, Transmission of Operative Resources and Education. And it's a not-for-profit that's actually under the Heinemann Foundation, which is associated with Sanger Heart and Vascular. And the mission's foundation is to create sustainable surgical capabilities in resource-limited hospitals in Central America through a combination of education and volunteer efforts. And so it's worth mentioning just that there's different types of global surgical outreach. And so this is a World Health Organization publication. And as you can see here, they have 4 types listed. The first, which is disaster relief, which is like the Red Cross. Next is short-term self-contained missions, which generally include bringing a whole team of both surgeons, anesthesia, nurses, et cetera, to sort of come in and do a high volume of cases in a short amount of time. And then there's specialty hospitals, which are basically sort of funded by the organization that is initiating them, and then being maintained through a partnership with local surgeons, and then kind of intermittently the surgeons from the US would come and sort of educate and help sustain it, but they're also funding it as well. And then finally, there's this capacity building and academic partnership, and that's really what the Restore group is trying to aim for. And so this style of outreach definitely is more of a long-term sort of play in mind, with a collaboration focusing on education in sort of a reciprocal manner. And so the advantage of this is that there's it's a little bit lower cost and lower requirement for personnel, but this is also one of the disadvantages, since not many team members are needed, and so not many surgeons can go. And so this is mainly to fulfill the goal of working alongside the local team instead of displacing them. And so capacity building and academic partnership can also be kind of summarized as educational partnership, which is a renewable collaborative effort to achieve mutually agreed upon goals and objectives in order to improve educational programs for learners and to strengthen relationships between communities. And you can see from these photos that there's similar faces sort of throughout the years, and that's because the surgical team in Honduras is really committed to the program and the continuous improvement of it. And so, what does it take to sort of start a program like this? You really definitely need surgeon champions on both ends with a committed goal to sustaining and improving the program. And so the surgeons in Honduras I mentioned before are Dr. Ochoa and Dr. Ramos. They were both there when Dr. Shu first went in 2011, but as I said, Dr. Ochoa kind of demonstrated some increased sophistication for understanding of limb deformity and also the leadership capabilities required for this type of position. But they both have come to the U.S. and done limb deformity courses, and Dr. Ochoa has also done traveling fellowship, and today they actually do most cases together, which really helps increase the efficiency of the case. And so we all know that change takes time. And so in 2011, not many of the surgeons really had any concept of what limb deformity surgery was. And now they have two expertly trained surgeons slowly distributing this type of knowledge of the surgical techniques. And so diffusion of knowledge in the healthcare setting is really similar to the diffusion of innovation, which is the process which an idea is communicated through certain channels over time amongst members of the social system. And if health education programs is thought of as innovation, then the pattern, this would be defined as the theory that could describe the pattern the target population would follow in adopting the program. And so the process of adoption, you can see here, it follows a classic bell curve with the majority of people being in the middle. And since this is the case, it does take time for diffusion of information and knowledge and change, as we know, which just emphasizes the importance of the continuous attention and implementation of the program. And so one of the coolest things that I got to see when I was down there was, really the sustainability and diffusion of this information that's progressed over time. And so the local participation has only increased, and more people are starting to adopt some of the techniques. So you can see on the top right here, this is Dr. Shu giving a talk on osteomyelitis. And in the crowd are multiple current residents, current attendings, and previous residents that traveled from all over the country to come and listen to him talk, who are practicing some of these techniques wherever they are. And along the bottom, you can see these were all taken at the screening clinics, which I'll talk about shortly. But it's always a team approach, and everybody is super enthusiastic and excited for the week when we get there. And so on an individual level, diffusion of information occurs over time as well. And so Dr. Shu through Restore has also started educating the residents here on a formal basis, which this is the limb deformity course that happens once a year. That's basically 2 consecutive weekday nights where all of the residents come together and learn about different limb deformity techniques. However, there's no amount of sawbones that will prepare you for the cases that you'll see when you go to Honduras. So unlike Bradwell's trip to Africa, the travel to Honduras is actually quite reasonable. Just enough time for Dr. Shu to catch a quick nap. The new airport in Comayagua is actually a lot safer and nicer to fly into than the one in Tencontin, which now only accepts regional flights. And despite our best efforts, we still had to endure a 2-hour customs inspection, which basically included them looking through 2 of our 6 checked bags and then ushering us into an air conditioning room while we waited for a receipt for 2 hours. Meanwhile, Dr. Ochoa was making some negotiations, and we eventually got out of there. But we did have to drive about an hour and a half then from the airport to Tegucigalpa, and Dr. Ochoa drove us. And so you can see here the country is beautiful, but that's about the extent of the landscape views that you'll see in this talk, which basically brings me to security. And like many Central American countries, there is some turmoil and political unrest within Honduras. And so the goal of the trip is really to do the work. There's no leaving the hospital unless you're with Dr. Ochoa or escorted by other surgeons. And unlike the US, the Clarion Hotel is very nice in Honduras. So it's not very hard to stay put there. Most meals are there, and there's definitely some time for a little bit of R&R, but not much. So part of the mission and support efforts as well is to bring some reprocessed circular fixation hardware there. And so when Dr. Shu first started Restore, he established a system and met with the hospital administration to basically set up kind of a reprocessing scenario through SPD. So when he does some of his frame cases at one-day surgery, the frames are removed and then sent to SPD like they normally are with everything else. And then it's reprocessed, sterilized, and then sent back to one-day surgery where anybody from a resident to their mother to Dr. Kempton to a med student may find one of these Honduras packages sitting around where the one-day surgery people will ask you to take it. And then it eventually makes it to Dr. Shu, who keeps it in the storage locker until about 2 weeks before the trip where pack up. And so Dr. Ochoa sent us a list of things that they needed about 2 weeks ahead of time. And we packed up these suitcases, which we checked. And we really could only pack, up to the max capacity that they would allow for us to check bags. And so we brought a bunch of, circular fixation rings, struts, et cetera. And then when we got there, we brought them all to the hospital and unloaded them in the resident room where we would use them throughout the week to repack our sets, and then they'll use them long after we're gone as well. And so there's also a process of purchasing implants in Honduras, which mainly consists of things going inside the body. So it's half pins, wires, et cetera. And Dr. Shu's actually been buying these things from the same guy, Norman, at OrthoMed since he started, which again kind of helps sustain the local economy and sustain the overall program locally in Honduras. So the screening clinic is the first thing that happens when we get there. And like I said, the majority of residents come in on a Sunday to participate in this. And basically, you can see here on the left, this was in 2015, and the number of patients in the clinic has actually gone down over time, which is a good thing because that means that Dr. Ochoa and Dr. Ramos are actually doing the majority of the cases by themselves now and really only saving the really complex ones for us. And so this clinic is basically, all the patients line up and we go through each of them and talk about their situation, whether that be complications or issues that they're dealing with, and then ultimately select patients and book our cases for the upcoming week out of these patients, plus or minus a few inpatients as well. And so this is a great example of the diffusion of knowledge that has happened through this program. This is one of the first patients we saw in the screening clinic, and you can see here he has a beautiful bone transport regenerate that was done 2 years ago by Dr. Ochoa during the height of COVID without any input, and definitely not with Dr. Shu present by any means. And she had some questions regarding the docking site, but in this case, he actually just needed more time, and so no surgery was actually scheduled for him. And so the next 5 days consist of daily cases, which basically wake up in the morning, read, hang out, work out, eat breakfast. Dr. Ochoa arrives, and then we walk to the hospital, which is like a block away. And then once we get there, we usually have to wait around a little bit for the case to get started. Then we cross the roof, which is actually a shortcut. You can get to the ORs without crossing the roof, but it takes a lot longer. So, so this is the pathway that they've established. And Dr. Shu wanted me to film him doing parkour across the roof, and Dr. Ochoa kindly pointed out that it was more like geriatric parkour. So I just speeded up a little bit for the talk.
2x means it's twice as slow as.
Yeah, exactly. Then we'll perform complex limb deformity cases. We usually do 1 to 3 a day, or 2 to 3 a day. Come back across the roof, eat lunch. This is the outdoor cafeteria, rooftop view. Hang out over turnover time, and then pack our instruments for the next day at the end of the day for our cases. And then finally walk home, eat dinner, go to sleep, wake up, and do it all over again. So now I'll go through just a couple of the cases to sort of highlight some of the things that we were seeing down there. So this was a 26-year-old male, otherwise healthy, involved in a motorcycle crash. His initial injury was in July of 2020. He had a closed tibia fracture with an ankle dislocation. His initial surgery consisted of a tibial nail as well as a stymon pin across the tibial talar joint to keep it reduced. One of the interesting things about the surgical options for patients is that they have to buy the implants. So as you can imagine, nails are pretty expensive. So not a lot of people can afford them. If they can't, then they try to use something else like an X-Fix or a plate, et cetera. Sometimes the plates have been donated or are a little bit cheaper. But the type of implant you use is dictated by whether or not the patient can pay. And so, unfortunately, as you would expect, his ankle cartilage deteriorated. And his second surgery consisted of a hindfoot fusion with a TTC nail. You can see here we're already looking like we're in a little bit of trouble. He has some equinus, midfoot deformity, and some osteolysis. And as you might have guessed, he got infected. The TTC nail was removed, and then a hindfoot antibiotic-coated rod was placed as well, and the patient was put on oral antibiotics. Antibiotics are also a little bit dicey there, just in terms of availability. So not only do the patients have to pay for them, but they have to be available in the first place. And so IV antibiotics are extremely limited, and oral antibiotics typically consist of like doxycycline or Keflex. And so the patient did receive an undetermined amount of oral antibiotics. And then, 3 years later, still has this in place and is seeing us today in clinic. He's been weight bearing as tolerated, but with some pretty significant limitations. And so you can see here that he's got a number of problems. Limb length possibly, but not isolated. It's a little bit difficult to tell. He's definitely got some equinus, which you can see because he's hyperextending his knee. And the fact that he's not abducting his leg probably means he's a little bit short as well, because he's able to clear, he's able to clear his foot. And then he doesn't have a ton of pain when he walks, which hopefully means that his ankle is fused, but it's unclear at this point. And then there's obviously the midfoot deformity. And last but not least, question of whether he's still infected. So what's the plan of attack for him? So obviously we schedule him for the first case on the first day, naturally. And for a multifaceted problem, we came up with a multifaceted solution. So plan to put him in a circular fixation frame with a foot plate, do a supramalleolar corticotomy and gradual translation and lengthening, plus an acute dorsal closing wedge osteotomy for the midfoot correction. And so this is what we did. We removed the antibiotic-coated rod, tested the stability of the ankle fusion, which was rock solid, did the midfoot osteotomy and secured it with K-wires, and then later incorporated those into the foot plate. Applied the frame, foot plate, locked the struts, took the struts off, and then did this supramalleolar corticotomy, and last but not least, pinned the toes. And one of the best parts about choosing a frame for this case, which is seems obvious in this situation, but is the plan really doesn't change much if he's infected or if he's not, and whether or not the ankle is fused or it's not. Only the difference is we would put a full ring around the ankle if it wasn't fused for added stability. And so here is the final construct plus some x-rays. The supramalleolar osteotomy is complete, which is good, and the midfoot osteotomy K-wires are in the ankle joint, but that's okay because it's fused. And so in a few days, he will get a program set up for gradual lengthening and angular correction, as well as posterior translation. So here's another case, a 58-year-old male, status was a motorcycle crash, and he had a closed femur fracture, initially treated with open reduction internal fixation with a lateral plate that you can see here. Those of you familiar with looking at x-rays of infection, you can see that there's some involucrum on the lateral x-ray here, but there's also some loosening of the screws, all signs telling you that infection is imminent. Clinically, it's obvious as well. He has these chronic skin changes that you can see, and also evidence of a healed fistula. And so again, kind of mapping out the problems, his major problem, honestly, is infection. He is having weight-bearing pain, which is likely attributed to the non-union. And then also, obviously, is some hardware failure and a recombined deformity as well. And so For him, plan to remove the hardware and then do a thorough debridement and irrigation, including the bath bomb, as Dr. Shi refers to it. I call it the beta bomb. You can choose which one you want to use. But basically consists of saline, betadine, and hydrogen peroxide. And you mix it together and put it into the infected area and wait for 3 minutes and then irrigate it out really well with normal saline. And then we put, once we got the plate out, we put this fixation ring fixator on. And as you can see here, the goal is to keep the rings very low and cascade the half pins up proximally for added stability, but all the while allowing the patient to sit in a chair without hitting the frame, as well as bend the knee. And so the distal ring is, these are both 2/3 rings, and the distal ring is open in the back to allow for knee flexion. And then the proximal ring is open medially to allow for soft tissue clearance. And like I said, the goal is for him to be able to sit in a chair without hitting the frame. And so you can see here that he's able to bend his knee fully. We actually saw him later in the week in the hospital, and he was able to scoot to the edge of the bed comfortably. And you can see in the x-rays how far up the femur those half pins go. So the stability is solid, even though the rings are pretty low on his leg. So one more case, or a couple more cases. This is another 26-year-old male who was in a motorcycle crash. He had multiple injuries, including an open tibia and femur, as well as a patella fracture. And this was initially managed by an intramedullary nail in the femur, a tibia X fix, and he also had the patella fixed acutely as well. And if you look closely at these x-rays, you can tell something is very wrong. There's an AP of the knee and a lateral of the ankle, which is never a good sign. And so this was actually before we got there. Dr. Ochoa brought him back to the OR and did a deformity correction, got his leg straight. He was also a little bit short, so she put a frame on, and he's been undergoing bone transport for this, which has been successful. But like I said, this is a femur case, and so the tibia is actually not the problem. The bone transport looked great, and that was doing very well. Unfortunately, though, he did have pretty significant signs of infection in the femur. You can see here the involucrum and the erosion of the bone, as well as the sequestrum that is evident on these x-rays, as well as loosening of the distal interlocks, which is never a good sign. And so his problems primarily include infection, as well as a segmental bone defect that'll be present once we resect the necrotic bone, and then also has a circular fixator in place, which just has some positioning difficulties associated with it. So we ended up putting him lateral using a positioner, which you can see here, and then resected the necrotic bone. We did use x-ray for this case, mainly because we're going to be using a nail, but we first removed the hardware, then or the nail, and then localized the necrotic bone and resected that through a small incision. And again, significant debridement and irrigation with the beta bomb or the bath bomb, and then created an antibiotic-coated nail in addition to a cement spacer. And so you can see here that they make the antibiotic-coated nails in the exact same way that we do here. The only thing is they don't have tobramycin powder there, so they just use the Vanc and Gent liquid. And so they make the nail, and we use the extra cement over a gouge, which you can see in the right bottom corner. And then this is taken off just as it got hard, and then used as a cement spacer in the area of the segmental bone defect. So you can kind of see the intraoperative photos here. Honestly, the hardest part of this case was doing distal interlocking screws, or mainly just getting everybody to focus enough for the perfect circle, both with the C-arm moving and the patient moving, and the bed being semi-translucent. It was an interesting experience, but we eventually did get it done. One of the other things that just reminded me of is an interesting thing there is most of these patients are actually totally awake during their surgery. They get a spinal block and no sedation, or very light sedation. So they can talk to you, like they know exactly, they can hear everything, but they actually do pretty well. And they have a lot fewer complications associated with sedation. So this is the finished product here. Everything that's within that middle segment of bone is cement. And so that will be used for induced membrane, and they'll come back and bone graft at a later time. And so last but not least, we did a couple of staged reverse sural flaps while we were there. And Dr. Ochoa had mentioned that they were having some difficulties with the flaps dying. And so we kind of talked about why this might be, and decided to do a couple of staged flaps. And it's hard to see here, but this patient basically had a chronic open tibia defect and had a cement spacer in place there as well, which we removed. But she had initially a circumferential laceration around her entire leg, which is, possibly compromising the perineal perforator reverse flow. So by staging the flap, you basically are testing the viability of the flap, as well as stimulating angiogenesis to that area. And so we did this lateral with the X-Fix still in place, and Dr. Shu scrubbed for this case. And if the patient is lateral decubitus, there's this little trick here that you can actually squeeze the calf, and it'll sort of center the soft tissue for you, which makes it easier to map out the flap dimensions. And we debrided the anterior tibial defect as well and removed the cement. And so you can see here that basically you measure out the paddle for the fasciocutaneous flap, and then you elevate it all the way through. And this ligates the antegrade flow for the paddle completely, which is then making it dependent on the retrograde or reverse flow from the perforators. And so you want to undermine the flap with your index finger as far as you can, basically to essentially test the viability of it, like I said. Then you just suture it close, and if it lives, then you eventually will rotate it. If it doesn't live, then you don't lose very much. You usually can just do wet-dry dressings for that area and figure out a different strategy. So so far so good. We saw the patient a couple days after this procedure, and the flap still looks good. So we'll see how she does. And so I obviously don't have time to go through every case here, but if you do want a very, very detailed play-by-play, Dr. Shu, I think, tweeted every single case along with really good explanations. And just a little tip, since Twitter, for me at least, is kind of difficult to navigate. If you go to the media tab, it actually allows you to look at all the posts in a chronological order and follow the threads for each of the patients. So, after a talk like this and a trip, a lot of residents and attendings are interested in participating and going to Honduras. But like I mentioned before, for various reasons, only a few can go at a time, mainly due to security as well as timing, and then the resources in Honduras. Typically, the resident or attending must be going into or and attending in peds for an ankle or trauma, because all we do is put on frames. So if you're not doing that, I don't really know why you want to go. But honestly, the biggest thing that is helpful for people at Hospital Escuela is donations, and the donations primarily go to medical equipment and implant purchases that we get when we're there. And this is just a thank you to the donors of Restore, primarily Dr. Joe, Chris Shu, and then SDT Financial often provides resident travel support, as well as the Baxter Foundation, which donates implants. Thank you.
That's a great program. It's really important to have that local partnership, and I think that's one of the reasons this has been so successful, in addition to Dr. Shu's energy and all of you all being a part of it. But my parents were missionaries in Haiti for 8 years, and it's not sustainable if you don't have good local surgeons that buy in. So that's really one of the keystones to it. So congratulations for developing those relationships. hoping to do something similar in Africa.
I mean, along those lines, even more impressive is 2011 was the first trip. So we're over a decade of this partnership, and obviously has elevated. You can see from that tibia that Dr. Ochoa did before you guys got there that, you know, the care being provided is at a very high level.
Yeah.
I'm positive due mostly in part to the longitudinal support given. So congratulations to for you for this trip, and Dr. Shu and Dr. Bright in the past, and Dr. Brand